इसके बाद तुम्हारा है। उधर सुनाई नहीं।
Hello, hello, sir. Excuse me. We are ready with the next block, sir.
जा रही है आपकी आवाज?
Hello, Divesh, sir. Yes, we are ready with the next block. They'll just brief you about what the patient is posted for. Uh, yeah, so we are ready with the next block, everyone. So this is a 36-year-old female with cholelithiasis, and she is posted for laparoscopic cholecystectomy. And Dr. Hetal sir will be given rectus sheath block and EOI, external oblique intercostal block in this.
Good morning, Divesh. Can you hear me?
Yes, sir.
Hello. Am I audible? Yeah. Thank you, Divesh. Good morning to all of you. So I'm going to demonstrate bilateral rectus sheath block and external-oblique intercostal plane block for lap cholecystectomy. So basically, I will demonstrate rectus sheath block one in the short axis and one in the long axis, so that yeah. So first, I will start with the scout scanning. So I have put the probe above umbilicus in the midline. You can see the linea alba. Can you see it? Is it visible, Divesh?
Can we have the ultrasound screen, please? Yeah, it's visible, sir.
Yeah. So I'm going laterally, and I will try to see the rectus abdominis muscle. You can see the rectus abdominis muscle now. You can see anterior rectus sheath. You can see posterior rectus sheath. And my aim is to deposit the drug above the posterior rectus sheath to block anterior cutaneous branches of the intercostal nerve. When I deposit this drug above umbilicus in the rectus sheath, it will block anterior cutaneous branches of T6 to T9 and up to T10. So first, this is in the transverse scan. Then second, I will demonstrate in the vertical plane or in the longitudinal axis. So my needle is coming in plane from medial to lateral because I'm giving block on the right side and I'm standing on the left side. So I'm putting my needle. I'm using 100 mm needle. I loaded 20 ml of 0.2% ropivacaine. From that, I will use roughly reverse. Yeah, I am coming from medial to lateral.
Okay. So you're giving right side block first.
Yeah. You can remove it.
Can we remove the SMPE profile?
You can remove it. You can remove it.
Will you tell this aloud to the audience later words? So right now it is creating a distraction. Yeah, thank you.
My needle is not visible. Yeah, now you can see the needle. Can you see it?
We can appreciate.
So I am on the anterior rectus sheath. So I am feeling the pop of the anterior rectus sheath. I have gone through the anterior rectus sheath. I am going. So I am close to the posterior rectus sheath. You can see. Now I will ask Dr. Neeta to inject few ml of drug here. Yeah. So I will a little bit advance my needle. Can you give it again? Yes. Now it is spreading in the right plane. Can you appreciate it, Dr. Divesh?
Yes, we can appreciate.
Yeah, so it is lifting the rectus muscle and it is just above the posterior rectus sheath, and it will block anterior cutaneous branches of the intercostal nerve. I'll inject 15 ml of LA here, and that is more than enough for rectus sheath block.
Can you increase the depth? So I think we've gone one layer much more ahead. I think you need to withdraw because.
No, I'm there on. Yeah. Sometimes there are multiple layers of the sheath and it gets separated. Yeah, so we have injected 15 ml of LA, and I will show in the long axis also. You can see this is in the, I make the probe in the long axis and you can see the drug spread. So it is spreaded nicely across the sheath, right?
Yes.
So now on opposite side, I will give with a longitudinal view or in the vertical axis. So again, I am scanning, this is in the short axis, and I am making the probe in the long axis. And you can see the anterector sheath and posterior sheath in the long axis. Can you appreciate it?
We can appreciate.
Yeah, so this is anterior and this is posterior rectus sheath and this is the muscle. Especially when you are giving the block in muscular patient, there are septa from anterior to posterior rectus sheath and that won't allow drug to spread into entire plane. So if you are giving in long axis, you can cross that septa and inject the remaining drug. So that's why long axis, I prefer to give this block in the long axis. So I'm coming from caudal to, cranial to caudal and I'm inserting the needle. I don't know
So
why.
underneath the rectus abdominis, you see two white hyperechroic lines. First one is the posterior rectus.
So this is on anti-rectus sheath.
These two lines should always be preserved. So you have to inject between rectus abdominis and the
Yeah.
posterior rectus sheath. This double line appearance is known as tram track appearance, which you try
Yeah.
to preserve.
You can start it. So you can see the spread now in the long axis. There is some air.
Rituja, don't you think you're intramuscular?
No, I am advancing the needle. Now you can see the spread.
Yes, yes.
Right?
Yes.
So my needle is in the plane. I am on the posterior rectus sheath and below the muscle, and you can see the drug spread. So now I'm adjusting the needle, and you can see the drug spread. Even I can change the direction a bit to go little ahead and inject more drug. Yes. So that drug spread will be better.
Okay.
Alright, so we have injected 15 ml of LA. I am again making the probe in the short axis and you can see the drug spread in the plane. Right?
Just wait for 1 second in the center of the pool of the drug. Yes.
Yeah.
Can you give it the center? Rituja, उसको image को center में कर दो. हाँ, बस.
Yeah.
So right now, can you see the double V sign? This one V and this one V. Can you appreciate this double V sign? This is a sign for successful facial block deposition of the drug. This is known as double V sign for any facial block, wherever you may go. Now please, are you clear?
ठीक है. So now I will demonstrate external oblique intercostal plane block on the right side because this is left poly patient, so I won't be bothered about left side block, but I will give the block on the right side. So for external oblique intercostal plane block, I will target 6th or 7th rib, little bit lateral to the mid clavicular line. I'll look at the rib, sterilium, thoda डालो, sterilium, sterilium, either. So I'll put the probe and try to locate the ribs. This is 6th rib. I'm going little bit laterally towards from the mid clavicular line, and you can see the rib. You can see the rib. You can see the external oblique muscle. You can see the pleura as well. And I will deposit the drug between external oblique muscle and the rib or intercostal muscle. So that is my target. So I come from cranial to caudal. You can see my needle is coming. I'll try to hit the rib rather than going towards the intercostal muscles to prevent the puncture of the pleura. I'm just on the rib, and I will ask Dr. Neeta to inject the drug. I will inject 20 to 25 ml of LA here. You can inject. Yeah, so once plane is created, I will adjust my needle more in the right plane. You can see the spread of the drug now. You can see the drug is, yeah,
can appreciate.
yeah. So drug is spreading in the between external oblique muscle and intercostal muscles, and I will inject 20 ml of LA here, 20 to 25 ml of LA here, because I want a larger spread, and I want to block T6 to at least T10 for left cholecystectomy patient. So Dr. Neeta has injected how much? 20 ml. I will inject 5 ml more, and I believe it will take care of left chole pain.
Yes, perfect. double BC. So any questions on these two blocks, rectus sheath and external oblique? So rectus sheath block is our go-to-get block for midline laparotomies. If you're extending from T6 till umbilicus, do a 2-quadrant block. If it's extending from T6 till suprapubic, do a 4-quadrant rectus sheath block. Below the umbilicus, we have an arcuate line.